Welcome back to the Barbell Medicine Podcast. I'm Dr. Jordan Feigenbaum, and today we're tackling a topic that has fundamentally changed the landscape of health, weight management, and chronic disease: the rise of anti-obesity medications, specifically GLP-1 receptor agonists. Now, whether you're an athlete, a health or fitness professional, or just someone trying to navigate your own health, you've heard the names Ozempic, Wegovy, Mounjaro, but the story has evolved rapidly, and so has the data. And in this podcast, we'll provide an update on these medications. Are they just for weight loss, or do they also help with other medical conditions? And just what does the data say about efficacy, side effects, and the loss of muscle mass? To help us out, I have two of the best minds in the business. First, the second most handsome doctor in North America, Dr. Austin Baraki, and obesity medicine expert, Dr. Spencer Nadolsky. Welcome to the show, guys.
Am I the third?
I don't know. I just assume that everybody that we ever have on the podcast is in the top 10.
Okay. I'll take top 10. I'll take what I can get, honestly.
No, that's yeah, for sure. But people are like, "Are you Jordan? Are you the most handsome?" I'm like, no. This is an inside joke, and if you're a longtime listener of the show, you know who's the most handsome doctor in North America. But anyway, Dr. Baraki, what's going on, man?
Hey, I'm doing okay. Glad to have Spencer here to cover this topic. I'm attending on the wards in the hospital at the moment, but able to sneak away and set some time aside for this conversation.
Yeah, and then if you guys don't know who Dr. Spencer Nadolsky is, he's been on the show. I think you've been on our podcast a few times. We've been on your podcast. We actually met when I was in medical school in Virginia. I believe you were in residency at the same time. Yeah. Shout out to Norfolk.
Jordan drove up in his M4 while he's in med school. And I was like, Jesus Christ, I'm resident. I'm freaking poor.
Well, yeah, that barbell medicine money,
Big barbell.
Yeah. Can you, before we pop into this, we do have a lot of questions and a lot of stuff to get to, but real quick, Spencer, can you give people just a rundown who may not be familiar with you, what your background is and what you're doing now?
Yeah, very quickly, NCAA athlete. I was a heavyweight wrestler, UNC Chapel Hill. I actually went to Michigan State to play football. I wrestled there as well. Ended up transferring, trying to do both. Realized I wasn't Bo Jackson, had to pick one sport. Ended up going with wrestling, then went to med school, went to Virginia College of Osteopathic Medicine at the time. That's what it was called. It's now Edward Virginia College. Went to family medicine residency at VCU in Newport News in Virginia. After residency, 2014, that's when I met you, Jordan. Then I specialized into obesity medicine and lipidology, really interested in innovating delivery care models. And so, we all worked together at a startup called SteadyMD, very quickly started doing all sorts of other stuff and made a company called Sequence, which was bought by Weight Watchers. I then left Weight Watchers to recreate a new company, kind of an evolution, online cardiometabolic direct care model practice I call Vineyard. So that's the gist, really. And we have a podcast called Docs Who Lift, so we're all meatheads here. A lot of meat flowing around in this podcast.
And then, Dr. Baraki, you're actually starting with Vineyard. You're going to be taking some online patients starting in December, I believe. Is this breaking news?
This is breaking news.
I suppose it is breaking news. I mean, yeah, so Spencer and I have known each other for a while in the telemedicine space, worked together for a while in the past at SteadyMD, and I've been doing telemedicine, I guess, since 2017 or so. Maintained a panel of primary care patients, was doing essentially full scope primary care, metabolics, health management, cardiovascular risk management, things like that. So this is something that I've been doing for a while, but I think am intending to expand, given that there's a lot of need out there for it. And Spencer is certainly a leader in this space, and we're in this shared communal space of docs who lift, who are interested in this topic. And so, felt like a natural next step to expand my existing practice in a way that is well supported by the organization that Spencer set up. And I'd be happy to have him speak a little bit about how he has it set up and what we're doing there.
Yeah, I'll now be not the strongest doctor at my my own clinic. Yeah, so the concept is, so everybody knows about, we're going to talk about these GLP-1 receptor agonists and just the field of this. It's kind of cardiometabolic medicine, I would call it. It's not the old kind of obesity weight loss doctor just focusing on the scale and pounds lost, where, if you, obviously people follow the barbell medicine discussions, we're talking about lipid management, probably a lot of blood pressure management, glycemic management. It's really this concept of cardiometabolic. So not just pounds lost, those translate into a lot of cardiometabolic improvements, but you really got to think of this person in their context and their comorbidities. So like if they have cardiovascular disease, what if they have liver disease, all sorts of these different angles. And it's going to require smart people like Dr. Baraki to think through who are the right candidates for each of these types of medicines. So that's what we're doing. We really think of it as like I hate to use the cliche term of holistic care, but really holistic cardiometabolic care that focuses on obesity, but really wraparound care online.
That's great. Yeah, we'll put links to that if you want to work with Dr. Baraki. If you want to check out Vineyard, we'll put that in the show notes. Let's get into this podcast. We'll start a little bit by taking a step back. So before we get to the drugs, Dr. Baraki, can you quickly explain what GLP-1 actually is and how it influences our body's function, especially appetite and like feeding behaviors?
Yeah, that's a super huge question, and we're going to keep this discussion, this part of it, the basic science side, I think, a little bit high level. So GLP-1 you could think of as a hormone. These are little peptide molecules that our body secretes from one area of the body, end up traveling through the bloodstream and having effects on distant organs and sometimes on more nearby organs. And so GLP-1 or glucagon-like peptide 1 is a hormone that is released from the cells of our intestines, usually after food ingestion. It has a few different effects on increasing the secretion of insulin from the pancreas, decreasing secretion of glucagon, slows down gastric emptying. But also we found that these receptors are pretty widely distributed throughout the body in all sorts of tissues and including in the brain. And this is part of how we think that they have a role on impacting and regulating things like appetite and feeding behaviors and things like that. But that they are so widely distributed leads to a lot of the other kind of potential benefits and some of the potential downsides that we'll end up talking about a little bit later. And I think that that's probably about as sufficient of a level of depth as we need for now. Anything important you would add there, Spencer?
No, I think that's great. Have you ever talked about like the incretin effect? I think people might be interested in
Go
kind
for
of
it.
that effect. So the incretin effect, what these drugs are, 50s or 60s, they injected glucose into people's veins versus having people ingest glucose. And like, I don't know, it would make sense that if you injected glucose straight to the veins, the glucose gets to your pancreas quicker. There's a bigger release of insulin as opposed to kind of this delayed increase in glucose in your serum. But what they found out is that people that drank the glucose had a larger insulin response, area under the curve, total amount of insulin release. And so they called it this incretin effect. They didn't know what the hormones were. Some intestinal secretion of a hormone. So incretin, they were like, all right, incretin. Then it wasn't until later they found the various incretins out there. And so the GLP-1 was obviously the one that they started going towards for big pharma. Some cool history there. But yeah, that's the only thing I would add. It's just a really interesting story of how they discovered this.
Yeah, between that and Gila monsters, there's a really interesting background here, but for another podcast. So to Dr. Nadolsky, this is something I've seen you talk about, and people certainly are going to ask about it. We hear about nature's Ozempic or like natural ways to boost this GLP-1 hormone that Dr. Baraki just described. Do we actually need drugs for this? Like, do we need pharmacological doses to actually get an effect here?
Yeah, so this kind of goes back to the history of this whole figuring out for big pharma how they tried to develop these drugs. We have an enzyme called DPP4, dipeptidyl peptidase 4. It breaks down our own natural incretins, and GLP-1 being one of them. So it breaks down within a minute or two. So even if we increase our own natural GLP-1, it doesn't necessarily have the effect on appetite that we'd see with these receptor agonists. We do actually have, and I don't know if you've talked about in the podcast, drugs that inhibit our own DPP4. So like sitagliptin, if people have heard of that, or Januvia, if you know the brand name. And those can increase our own natural GLP-1 by like 2 to 3-fold. But we see glycemic benefits, like blood sugar benefits, but not really weight loss or appetite differences. So we can just briefly chat about the Gila monster. I don't know if it's Gila or Gila. It doesn't really matter.
It's like a GIF or a GIF,
Yeah,
like
it
it's like the same
doesn't
thing.
really matter. The little lizards out in the desert that they were studying them for, there's a few reasons why, but they thought it might have something to do with blood sugar. And it was serendipitously, they found that the venom was like similar to our own, there was a part of it that was similar to our own GLP-1, but it was resistant to breaking down by our DPP4. So that was like how the first drug, Byetta, came out, or exenatide. And later they've developed these GLP-1 receptor agonists to basically be resistant to our own DPP4. So Nature's Ozempic. I just did a video, a response video. There's an internal medicine doctor saying, you got to eat more fiber and take probiotics to increase your own GLP-1. That's how Ozempic works. And it's like, no, these drugs are their own agonists. They are analogs. They're synthetic versions that are not broken down by our own natural enzymes, the DPP4. And that's what makes them so powerful, because then they can stick around longer and hit the receptors differently and actually get to the brain to have those appetite effects. So even if we increase our own natural GLP-1, there may be some glycemic benefit, but we're not going to see much of an appetite difference.
Yeah. I've talked about a few times that, like, yeah, you can increase your own GLP-1 a bunch of different ways. Unfortunately, it's usually not large enough, and it's not long enough lasting to have the same effects as these medications. So anybody who's trying to sell you a GLP-1 supplement, or like a way to increase your own GLP-1, you can just ignore them. That's basically a good takeaway there. All right, back to Baraki. Now, the science is moving quickly here. So can you walk us briefly through the evolution of these medications from, first short-acting injectables, I think you had to do them twice a day, to now we have agents that hit multiple receptors like Tirzepatide, and even some new oral stuff that's coming down the pipeline. Can you talk about this?
Yeah, I think a brief overview will be helpful. And it's been really interesting and fun. I think Dr. Nadolsky probably shares this, because the period during which we went through most of our medical training exactly overlapped with a lot of the development and dissemination and uptake of these medicines. Like, I vividly remember being in the endocrine clinic the first time I ever heard of the name Ozempic, and I didn't not have anywhere near the appreciation for what it was going to become or turn into at that moment in time. I was like, oh, this is just another new medicine like any others. Whereas, at the time we were still prescribing these DPP4 inhibitors like sitagliptin all the time, even though I recognize, like, this doesn't really work that well, but it's kind of what we have for this particular, situation where the patient wants an oral pill or something like that. But anyway, so yeah, we had the original discovery of endogenous, or like natural, the GLP that our body makes on its own, that only lasts, again, for a minute or two before it's broken down. And if I had to summarize the overall evolution of this class of medicines, it's been kind of engineering the molecules to do a few different things. One, to make them last longer. So going from, as you said, exenatide, the first one was a twice a day injection, which didn't even really work all that well. Extending it from twice a day to once a day with medicines like liraglutide that came and was approved in 2010, whereas exenatide was approved in 2005. I just point out the years so that people who question, do we have enough experience with these medicines? They have been around now for a couple decades. So longer duration of action from twice a day to once a week with medicines like Bydureon or Ozempic, dulaglutide, and some of the most recent ones are all once a week in general. And then we have upcoming ones in the pipeline that are going to be once a month, potentially longer, which will come with their own pros and cons to have drugs that act that long in duration. The other general trend that has happened with engineering of these peptides and these molecules is that they have increasing potency. So they achieve more of the effects that we're looking for. So more potency in terms of better weight loss effects, and better glycemic effects in terms of blood sugar and diabetes control, among others. And then the last aspect of the engineering that's important is less undesirable side effects, so better tolerability. So these medicines over the years, going from that first generation back in 2005 to the next generation around 2010 of liraglutide, Victoza, Saxenda, things like that, to the 2010s, Semaglutide, Ozempic, Wegovy, and then most recently drugs like Tirzepatide, Zepbound, for example. And then most recently, the ones that are kind of in the pipeline we're anticipating probably within the next year or so is going to be some of the oral medicines, and then some of the even more potent, what we'll call multi-agonists or tri-agonists like Retatrutide, however that is exactly going to be pronounced. And so all of these just in general tend to gradually last longer, more potent good stuff, and less bad stuff or better tolerability, I would summarize as the evolution of these medicines over the past 20 years or so.
Yeah, no, that's a good summary, and things are moving quickly, and it almost seems like daily or weekly that, oh, look, a new phase 2 or phase something trial comes out, and this one is oral, and you can only have to take it, every so often, which ultimately I think people are going to prefer more than the injections, but cross that bridge when we come to it. Last thing before we start getting into some of the clinical data that has emerged recently on how effective these things are is this concept of food noise. This is all over social media. Mainstream media has picked it up as well. Dr. Nadolsky, can you talk about this concept of food noise? Like, what is it and how does it relate to this topic?
Yeah, so it didn't really come out until these medicines so much. There was this concept of it, and it's always kind of been a thing, probably an evolutionary thing, because we got to seek out food and think about food to survive. But somewhere along the ways, it's likely related to our dysregulated appetites and why we struggle with helping people lose weight and keep it off. And people just thinking about food. Now, when people are trying to articulate it, I've asked, I don't know how many hundreds of patients about like, how would you describe it? And what they describe, it's not a craving. So cravings are usually something specific. So like after dinner, I really want some chocolate or potato chips or whatever, something very specific. It's not hunger. Everybody knows what hunger is. You've gone all day and you're like, oh my gosh, my belly is kind of, I need to put something into it. Cravings, we want the dessert or whatever. Food noise is really just, it's this relentless thinking thoughts about food. So what they'll describe is that it could be something healthy. It could be something not healthy. It just in general thinking about, is there going to be enough to eat at dinner? Am I going to go get seconds? Is there going to be dessert afterwards? And it's not something specific about it. What about the next day? It's like, and it's constant. They could have just eaten and they still are thinking about food. They could be just stuffed and like completely satiated, but like still thinking about food. And so it's a completely different concept to people. And they didn't realize they had it until they started taking the medicine. Like, for example, a patient said, yeah, I was able to enjoy my meal out with my wife because I wasn't thinking about whether my dinner was going to have enough in it. I wasn't thinking about the bread that was not here yet. It was just like they just actually enjoyed, like they could actually think. And this is maybe why some people feel like they have like less anxiety overall, like they feel like they have more brain power to put towards things that matter more in their life as opposed to just always thinking about food. Really interesting concept, and there's some new validated questionnaires. But in general, I just ask my patients like, do you think about food when you're not hungry? Yes, you can just ask them almost subjectively to talk about it.
Yeah, there's like a running joke in like amongst bodybuilder or like physique type focused people that are like, yeah, look, I'm eating one meal and then I'm actually thinking about the next meal.
Mm-hmm.
And on some of it's kind of humorous because it's like, yeah, we're losing weight, and so it's almost like an expected part of the journey. But for them, it's not. It's transient, like context specific, because they're actively trying to lose weight to get very, very lean for a show or something like that. And then also, it's not they don't perseverate on this indefinitely. Whereas I do tend to agree that people who have this maybe aren't even aware that it is a separate entity that's going on until it's gone, and they're like, "What was that? That I was always thinking about food one way or another." And again, not something specific or not like I'm actually hungry, but just preoccupied with food. And then when it's gone, they're like, "Huh, it's quiet. The noise is gone."
It's really interesting. So that's the gist. There's some Travis Masterson. There's a few of these psychiatry, psychology, neurobiologists kind of looking into the mechanisms of it all, as it's been studied before for eating disorder type behavior, kind of ruminating and thinking about food a lot. But like, it shouldn't happen in obesity constantly. They have enough energy stores. So to me, it's something pathologic.
Yeah, that's the thing. You would expect that if a person has expanded energy stores, they've developed excess body fat, excess adiposity, we'll call that obesity, that the body would subsequently compensate by reducing energy intake and reducing food-seeking behaviors and maybe even increasing activity to sort of maintain a normal and ideally healthy for reproductive fitness in the future level of body fat. But that's not what seems to happen in the modern food environment. So anyway, we could do a whole nother podcast on that, but let's transition to some of this clinical efficacy data. We've talked about some of the basic science here and kind of how they work by targeting appetite and the transit of stuff through the gut. But how well do they work? So this is to Dr. Baraki. So Dr. Baraki, semaglutide or Wegovy was studied in a series of studies known as the STEP and SUSTAIN trials. Those are just acronyms, among others. What were the main findings of these studies in terms of obesity?
Yeah, really encouraging findings overall without getting, again, too far into the weeds of the statistics and minor, variations in data between the individual studies, because each of these were kind of big collections of a series of studies run looking at slightly different outcomes along the way. In general, showed excellent effectiveness of these medicines, good potency on average. You'll hear a lot of kind of average weight loss data cited in these, which is just one metric of efficacy that you can look at. So on average, about 15% weight loss when these drugs were, studied over about 68 weeks or so compared to placebo, at least in the earlier studies, as well as the kind of what you would expect to see in terms of reductions in waist measurement, reductions in blood pressure, reductions in blood sugar, hemoglobin A1C, things like that. Again, some variation around those numbers, but that's kind of like a commonly cited average weight loss figure. But the other useful metric that I like to look at is proportions of patients who achieve the goals that we're looking for, right? So it's not just what's the average amount of weight loss, because there's going to be a distribution around that, but there's going to be a distribution around any intervention. So if it's a weight loss intervention that's not related to the use of medicines, just lifestyle, diet, exercise, some other weight loss related medicine, when we talk about what is deemed quote, significant weight loss, at least for health outcomes, what used to be maybe around 5%. In some situations, you'll hear people quote a little bit higher, maybe 7.5%. For some medical conditions, it's actually even more beneficial to get larger amounts of weight loss. What proportion of patients are achieving that level of weight loss if they get placebo over that course of time, compared with if they get the medicine over that course of time? And when I recently pulled some of this data together across a variety of these semaglutide studies and looked at, well, what proportion of patients achieved greater than 5% weight loss when they were on placebo, which was about 30%, which is actually a little bit higher than I would expect and higher than we tend to see in practice, but about 86% achieved it on the medicine. And so we can see that it shifts dramatically. Like if you imagine a bell curve of people's responses to these interventions, it shifts that whole curve of more people are achieving the target, regardless of what the average amount of weight loss is, but we're getting more people the outcome that we're looking for, which then translates into a lot more downstream benefits on health, which is the main thing that we're talking about here. So that's my overall take on the semaglutide data.
Yeah, not only like a big effect, so like just in general, greater amount of weight loss. So people achieving that clinically significant weight loss, they go beyond that, but a greater proportion of folks make it there too compared to lifestyle alone. So yeah,
exactly.
big effects here. Spencer, Tirzepatide or Zepbound, Mounjaro, has been studied in the SURMOUNT trials. And what were the findings from these studies that you found most compelling? And maybe you can contrast those to what we learned about semaglutide from the previous data.
Yeah, it's somewhere around like 30 or so percent stronger in terms of total amount weight loss. And you can see the responder data, the categorical weight loss is just stronger as well. So we see just over like a 20 or so, 21% total body weight loss over the course of like 72 weeks. And so they've done a head-to-head in one of these studies and showed like it's better, a little bit better tolerated. And anecdotally, we noticed that as well. So a stronger drug that's better tolerated, just a better profile in general. We didn't get into like the SELECT trial with the cardiovascular disease reduction with semaglutide, but like patients prefer Tirzepatide. So when you're thinking about 20, 21% total body weight loss versus like the 15 or so percent total body weight loss with semaglutide, high dose semaglutide. Actually, we'll probably talk about, they did another study, Step Up. They did a very, very high dose Wegovy semaglutide. They got a little bit more, like 17 or 18% total body weight loss with that. But in general, even just the lower doses of even 5 milligrams of Tirzepatide, which is the second lowest dose, gets about the same that you would see with 2.4, that the previously highest dose of Wegovy semaglutide. Better tolerated. It's just I'm not even paid by Lilly, but
yeah. What's our conflict of interest thing?
I did a Novo ad board, and I just felt bad because I'm just like the Lilly drug's better, but like if you can make this cheaper. So anyway, I like Tirzepatide much better. Just the data is pretty clear on that.
Yeah, it does sound like Tirzepatide is generally superior to semaglutide, all else being equal. But Dr. Baraki, what does the pipeline look like? Are triple agonists like Retatrutide going to push this even further? Like, Is that what we think the advantage is to tirzepatide?
Yeah, I think so. It's interesting to see because I think a general theme in medicine and a lot of other areas is like when you see a drug or an intervention that has a lot more potency, you might in generally expect, okay, well, more effect in general might also come with more adverse effects in general. And so seeing the effects of, I guess, bioengineering, really smart people doing these things to these peptides to achieve simultaneously higher efficacy of the things we want with less adverse effects of the things we don't want is a really unique combination and speaks to the level of I don't know, expertise and incentives that are at play for them to get this right. And so that's what we're seeing with the newer agents like the one you just mentioned, what's being termed a quote unquote triple agonist because it hits multiple different receptors. And again, setting the details of that basic science aside, hitting multiple receptors lets us target multiple different pathways to achieve the effects we want and add on additional beneficial things. We've talked about this before, for example, when we recently did like our blood pressure update, and I talked about how a lot of the time when I have a patient who's willing to do it, I tend to use multiple lower dose medicines to get the bang for my buck from multiple meds with less side effect risk. Same thing with lipid or cholesterol lowering therapies, using different medicines at lower doses that work in different ways, because we know that hitting different pathways that all kind of converge on a similar outcome, we can get a lot of effectiveness. And by keeping the doses on the lower side, if that's feasible for a given patient, then we can mitigate and avoid most of the tolerability type of issues. And so what we're seeing with these triple agonists and the data coming from Retatrutide is that it is more potent, achieving now into the mid-20s on average, like 24, 25%, say, weight loss, starting to compete with metabolic bariatric surgery efficacy, and then also having some seemingly, unique aspects to it. The glucagon receptor that it targets, I've seen some discussion that it maybe like increases energy expenditure, maybe helps to accelerate, the resolution of fatty liver disease as a result of that. Maybe a little bit more lean mass sparing, which would be awesome as well. And so again, I think the level of expertise and incentives at getting this right are leading to just phenomenal development of these things to get all the things we want with less and less of the things we don't want coming out.
Yeah. I found the development pathway super interesting, mainly because, as you said, the incentives. It's like, oh, look, if we can make this work better with less side effects, yeah, we're going to do it. And it's like, wait, if big pharma was super evil, like that doesn't necessarily seem like the move there. But it'll be interesting to see if Reta gets, once it gets past all the phase 3 clinical trials and there's some better dosing and monitoring sort of profiles available for that. But yeah, it's out in the wild. People are obviously like using these research chemicals, which we're going to talk about shortly. Not my favorite thing, but we'll talk about that. Before we get there, though, Dr. Nadolsky, because of this pipeline is being just kind of pushed to the nth degree, there are some oral options coming down the pipeline. And I suspect, as I talked about earlier, that people are going to prefer an oral option compared to, self-injecting or whatever. What are you expecting from some of these oral options coming out?
Yeah, there are two of them that are going to come out 6 to 12 months from now. They just put on a fast track for orforglipron. I used to say orforglipron, but it's apparently orforglipron. Whatever. It's a small molecule. It's supposed a big, huge peptide that you have to inject, or with the semaglutide oral, you have to put it in this special packaging that changes the pH of your stomach to be able to actually not break it down and absorb it, which I'll talk about in a second more. Orforglipron is a small molecule, so you can actually take it orally with food. You don't have to worry about drinking tons of water or anything, other medicines interfering that I know of. And it has, around like 10, 11% total body weight loss. We don't have all those cardiovascular trial data like we do with the oral semaglutide, which I'll talk about in a second. But, somewhere around like a 10 to 11% total body weight loss. It's supposed to be cheaper because it's easier to make because it's just a regular molecule instead of a peptide that needs all this special transporting and things like that. So I'm kind of excited to see that, because if it's cheaper, and we'll talk about the prices and stuff about people trying to maintain their weight loss and having to come off the medicine because of price, this might be something that would be of use there. And hopefully they do cardiovascular. I think they're going to do some cardiovascular trials to make sure As we've seen before, other drugs where we thought were going to be really good, in the end, there might have been some bad things happening that we just didn't know about. And some of the oral drugs, oral small molecule GLP-1 drugs that didn't come to the market, they found some of these through the phase 1, phase 2 trials, which is a testament to why we do all these phase 3 trials and even further post-market surveillance. So that's orforglipron, small molecule, not a large peptide. They can make it easier to make, cheaper to do. They have a ton of it stockpiled that they're ready to launch here. Again, I'm not getting paid by Lilly, but it's excited. That's a Lilly drug.
Yeah.
The other one is high-dose oral semaglutide. So we already have this available in the form of a type 2 diabetes branded drug, which is Rybelsus, if anybody's heard of that. That's been out for quite a number of years now. Not super popular, though. It goes up to 14 milligrams. This new higher dose version, they're going to allegedly call it like oral Wegovy. That's what I've heard through the pipeline, which I don't know. Whatever. Oral Wegovy is what they're going to call it. So it's high dose. They actually studied it first at 50 milligrams. That's 50 milligrams. So it's about a 10-fold difference in absorption. I talked to a PharmD on my podcast all about it. So they put it in 50, but then they found that the 25 worked pretty well. And it's around, somewhere around 14, 15% total body weight loss. It's not bad, not a bad option. And they have that cardiovascular disease data that we can discuss here. But not a bad option, but it has to be packaged in the snack package that allows your stomach to absorb it. Because otherwise, if you take an oral peptide, it gets degraded by our own stomach acids and won't be absorbed, it'll be broken up and everything. So they have to put it in this special thing. You have to take it with a tiny little bit of water in the morning, no food for a while. Now, the question of whether people would prefer it. So what's interesting is my patients almost love the weekly injection. It's because I thought the same thing. Maybe people would love taking just a pill. They love just because the needles are so small. They're teeny tiny. And they're some people are afraid of needles. I'm like, just do it and let's see what happens. And they're like, I didn't even feel anything. So a lot of patients actually love the weekly injection, but I don't know. We'll see. I think really what it comes down to is price. If you can make these things cheaper, that's going to take the cake. Whatever's the most powerful, but then the expense really takes the next.
Yeah, not that anybody's asking me to name drugs, but like oral Ozempic seems like a way better thing than like oral Wegovy.
Yeah, I know.
Yeah, look, I'm available. If you guys need me to consult on drug naming, I'm here. All right. Well, look, we've talked about some of the efficacy, very, very effective. But there are some cool other benefits to these medications that have been coming out. And I think there's some interesting stuff here, not only with like weight loss associated benefits in things like, heart disease, certain types of cancer and so on and so forth, but also weight independent effects. So like maybe these medications do something on their own to reduce the risk of either disease development or disease progression that's independent of weight loss. So Dr. Nadolsky, what have trials shown so far in terms of like the impact on heart health or cardiovascular health from these drugs?
Yeah, so the semaglutide is the big one that we saw a couple of years ago. Actually, it's pretty much 2 years ago. The SELECT trial, at least the top line results came out. I believe the full study came out, but SELECT trial was Wegovy in those with a history of obesity and cardiovascular disease and not type 2 diabetes. So we've seen benefit in the past. My brother always talks about the LEADER trial with liraglutide. Now that was like whatever it was, 10 years ago. So that was the first drug to show cardiovascular benefit in those with type 2 diabetes at high risk cardiovascular disease. This was the first one that I know of that people did not have type 2 diabetes, but had a history, baseline cardiovascular disease. And what they showed is a reduction in major adverse cardiovascular events. And they've done further analyses to show like, it doesn't look like it looks like it's mostly, maybe at least 2/3 of it's unrelated or independent of the weight loss. And when you look back at studies, we thought that like around a 10% total body weight loss, whether it's from lifestyle, bariatric surgery, would lead to reductions in cardiovascular events. So that's kind of what they were thinking. But now with some of these other drugs, like they've had older GLP-1 receptor agonists. Albiglutide was one of them. There was that was for type 2 diabetes, but people didn't lose any weight, but they still improved their cardiovascular event reduction. Like there was improvement there. So there are receptors all over the myocardium. There's receptors in our endothelial tissue. There's receptors, changes in our immune system. Something's going on with this GLP-1 receptor agonism that goes beyond just the weight loss. Of course, we're going to see blood pressure improvements. We're going to see lipid improvements and just overall mass in general, which may be a less strain on the heart. But like there's something else going on just from taking a GLP-1 receptor agonist. So for the heart, I think that's what's really exciting. We're waiting on Tirzepatide data. There's a Tirzepatide study similar, but they're actually doing in like primary prevention as well. I don't know. So I'm sure you've all talked about differences between primary and secondary prevention. So primary would be preventing that first heart attack. Secondary is somebody's had a heart attack or heart event, and you're preventing another one. So the Tirzepatide, the Surmount MMO, they're looking at like, it's going to be really interesting. I think it's going to be positive though, and good.
Yeah, no, this is just a brief aside. You're hearing Dr. Baraki, Dr. Nadolsky, and sometimes myself talk about all these various studies that are very specific to a particular intervention, in this case, a medication, in a particular population to come up with a particular outcome to see if that changes. Contrast this to mechanistic data in exercise science, where it's like, look, if you fast, then your growth hormone level goes up some percentage, and people are like, yeah, that'll probably lead to more muscle mass. And it's like, do you know how many steps you've skipped in the middle to get to that point? And in medical research, particularly in agents that have a lot of evidence and data behind them, you can feel quite confident in saying, look, if you are in this population, you have a high probability of seeing some level of this effect, and it's relatively well characterized, which I find very reassuring. Just to if you're advising somebody on taking these medications or to not take these medications or other medications, it can all be useful there. Compared to it's mostly vibes. Like we have like a mechanistic like plausibility, but we don't have like good outcome data, or the outcome data we do have is not good. In that case, you're like, I don't even know why we're talking about this. But just a brief aside. Anyway,
Austin and I see this on Threads. They were talking about this. Very quick tangent. People do this with drugs and doctors. And I think it's because they don't understand study design and how to design trials to look at outcomes. So menopausal hormonal therapy, they're saying reduces cardiovascular events. It's like, it's a whole thing. We could do a whole podcast on that. And so Austin and I were going on Threads. I noticed he jumped in, and but it's not just exercise science. It's unfortunately a lot of other places too.
Austin and I have, I think, turned into Clippy, from Microsoft Word, the little guy. So we're like, hi there. What do you think the best direct human evidence is to show that this actually, changes this?
I enjoy it. They show up in my feed, and I always like it because it's always so funny. I'm always like, oh my gosh.
Yeah, you and your brother are we like seeing your likes because it makes us feel good about what we're doing.
Funny.
So to Austin, what about other major organ diseases like that of the kidney and that of the liver? I know there's evidence coming out here. So what do we know on that front with respect to these anti-obesity medications?
Yeah, several years back, there were just a broad policy about medicines that were being looked at for use in diabetes, that they were essentially all being required to look at cardiovascular outcomes, these things like heart attacks and strokes and things like that. But interestingly, we're also accumulating evidence in other very, very common organ system diseases. Obviously, as I mentioned, I'm sitting here speaking to you from the hospital where I have a ward full of patients with all of these things, be it cardiovascular issues, heart attack, and heart failure, which have been looked at with these medicines, as well as various levels, degrees of chronic kidney disease, all the way up to dialysis patients. And then my least favorite and the most horrific is advanced liver disease, which is something that we see more and more of these days. So when I went through training, I saw boatloads of, for example, hepatitis C related cirrhosis. Now that we can cure that condition, seeing less and less of that, but much more fatty liver disease that has progressed to steatohepatitis and then cirrhosis as a result, and then the complications of that. And so when this has been examined so far, for example, in the FLOW trial, looked at GLP-1 agonist and what they called kind of this kidney events, to borrow a term from the cardiovascular literature, things like progression of chronic kidney disease or death related to kidney-related causes. These medicines are showing benefit in that realm. And then similarly, when we look at, for example, the rates of fatty liver disease or resolution or improvement in fatty liver disease, improvement in inflammatory markers around fatty liver disease, which would all lead to a reduction in the risk of progression to cirrhosis and all of those really horrific complications that I have the pleasure of dealing with in the hospital. The more potent these medicines get, the more benefit we're seeing on fatty liver disease. And that's what I mentioned earlier, the interesting kind of maybe unique aspect of Reta that you mentioned as one that can maybe increase some energy expenditure, maybe has some unique benefits on the liver. Whether or not that ends up panning out and being fully accurate, just the sheer amount of weight loss that these things can induce, once you get well beyond 7.5 to 10% of weight loss, we can see essentially curing of fatty liver disease, which would be great to reduce the burden of chronic liver disease worldwide. So not only heart, but also kidney and liver, like 3 of the major chronic organ system type of conditions that are often also comorbid. They have led to this development of a new term that they're calling CKM Syndrome, or cardiovascular kidney metabolic syndrome, that kind of encompasses all of these things, people having heart disease and liver disease from fatty liver and kidney disease, as very frequently overlapping in patients. And we have increasingly potent and increasingly well tolerated agents in these medication classes that can somehow simultaneously benefit all of them, not only because they have a shared mechanism, but also because of some of these weight independent effects that Spencer alluded to earlier.
Yeah, maybe we can rebrand CKM as type 3 diabetes so people don't inadvertently refer to that as like dementia, which is definitively not the case. That's another like quack watch red flag. If somebody calls dementia of any kind type 3 diabetes, you should just block and move on.
Doesn't even make any sense.
Yeah, that's right. Before moving on to some of the side effects we're going to talk about, there is other areas of emerging evidence coming out for everything from like sleep apnea to addiction, some forms of cancer, so on and so forth. So I'll have both of you weigh in on this. I'll start with you, Spencer. What are some of these areas, these other areas where these medications could be effective based on emerging evidence?
Yeah, so obstructive sleep apnea is pretty well established. There's a Surmount OSA trial. That's why they've actually made it FDA approved for those with obesity and obstructive sleep apnea. Medicare even allows for it. We see sometimes a resolution in obstructive sleep apnea. People stop needing their CPAPs. It's not all the time. Weight loss doesn't always improve obstructive sleep apnea or resolve it, as there can be some anatomical differences. But when you start getting that 10-15% total body weight loss, we start seeing reductions in the apneic events from obstructive sleep apnea. So pretty good data there. There's another drug called Qsymia that actually, it's not FDA approved for it, but it's a phentermine topiramate combo. So we do know that a lot of weight loss can result in improvements in obstructive sleep apnea. I do believe most of that is weight dependent. However, some argue there may be some other weight independent effects. It would be hard to tease that out exactly, but kind of interesting there. From addiction, so there's a new another Lilly. I swear I'm not getting paid by Lilly, but they just
we should get paid. Honestly, I'm going to text them after this because I have a direct line
I've
as part of like.
Someone's like, look, you guys got to start putting me on your ad boards. We'll see what happens there. But they're trying to find drugs that are made for alcohol cessation. So funny, so stupid, but I had a viral TikTok a few years ago when I started using a lot of Mounjaro. It was the type 2 diabetes version of Tirzepatide. When that first came out, I was using a lot of it off label, and people right away were like, wow, this is so weird. I don't really want to drink alcohol. And I was like, really? So I actually published some retrospective data of all of the changes in alcohol intake from our patient population of like tens of thousands of patients. Kind of cool to see that. So I believe that we're going to see other addictive like behaviors, people not biting their nails anymore, maybe even some gambling, sex addiction type of stuff, opioid addiction type of things. The drugs have a strong response in the reward center of our brains. And it really stops. So I think we're going to see addictive-like behavior improvements there. Other things, so anti-inflammatory things, so psoriatic arthritis, rheumatoid arthritis. Some of my patients notice, wow, I was on my biologic and it kind of helped me with my psoriatic arthritis, but it wasn't until I started Tirzepatide. Again, this is anecdotal, but when you go to Eli Lilly's research page of what they're looking at, the trials are doing, they are looking into this. So Big Pharma is not stupid. They're not going to pay gajillions amount of dollars to look into some silly anecdote. They're clearly seeing the signal too. So I think we're going to see a lot of really just interesting stuff there. I see gynecological improvements. People start having normalized menstrual cycles. There's GLP-1 receptors on the uterus, ovaries, and in the hypothalamic pituitary region. I don't know. It's some interesting stuff. So
Yep. Some of the most interesting stuff I've seen come out has to do with like cancer risk reduction. And it almost seems like, not to get too technical or jargony, pleiotropic effects of these medications. They're just affecting multiple different areas. Look, if there's a receptor there or like something that these things can bind to, it seems to have a decent effect. Dr. Baraki, what's your take on this like cancer risk reduction? What's up with that?
Yeah, I think that it's really difficult to study in the way it has been studied so far. Cancer is a very heterogeneous disease. There's so many different types of cancers. They develop by way of so many different types of exposures and things like that. So like looking at acute leukemia, for example, and comparing that to, estrogen sensitive breast cancer, they're like completely different pathologies. And so lumping these things into big buckets and looking at it in an observational way, which also lumps in a whole lot of other, variables that are not being equally distributed in a randomized trial, makes it kind of tricky. I find it plausible that that there could be some impact on cancer incidence, particularly among the adiposity associated cancers and things like that. But that's something that I would want, I think, higher quality data to try to tease apart. To what Spencer mentioned earlier, we already have, for example, some of that in sleep apnea. We already have that in osteoarthritis. We're looking or expecting that hopefully coming soon in some of the addiction space. And, I have some concerns around, the judicious use of those medicines in the addiction space, knowing that, hey, well, a lot of the patients that I see, because I see tons of alcohol-related issues in the hospital setting, and I have a few as we speak, who are not very well nourished, for example. And so then what's going to be the impact? They're not very well muscled. They're not very well nourished. They don't have, high-quality diets. They're not exercising. If I induce 20% weight loss in this person whose diet is comprised mostly of alcohol, what's the impact going to be? So there's some thoughts and concern, which is the lesser harm there, right? And in general, I'm trying to get people to drink less, and I will tend to accept a fair amount of risk in other ways because alcohol is like the most harmful thing that they might be doing. So there are going to be a lot of considerations around all of these areas. I share some of his observations around PCOS. There's also conversations around like maybe neuroprotection, dementia risk, things like that will also be super interesting because, we've seen cardiovascular disease remains the number one killer, but on a per capita basis, rates of death from cardiovascular disease have been declining for decades now. We're making a lot of progress there with all the tools that we have at our disposal. Now we seem to have one that's going to be helpful for obesity and the obesity-associated comorbidities. The longer we live without dying of things like cardiovascular disease or kidney disease or liver disease, the longer our lifespans extend, it's going to be more and more cancer and more neurodegenerative disease. And so if these have a favorable impact on those things, that would be a win on those fronts as well. So super interested to see how it plays out.
Yeah, what I'm hearing you say is that if we just take Tirzepatide or Semaglutide and you stack it with creatine, effectively you're going to live forever.
10 grams daily, right?
30 grams. 30 grams.
30, yeah,
Oh, 30,
more grams.
All the
better.
grams.
So many grams. All right, well, let's transition to some of the side effects because with any effective medication, there are no biological free lunches here. So there are risks and side effects. So let's discuss some of the common side effects and some of the rare but serious ones. So Spencer, what are the most frequent side effects that people should be prepared for, and how do you go about dealing with them in your practice?
Yeah, by far number one is nausea. Very common. We saw this very early on with exenatide or Byetta and all the GLP-1 receptor agonists. In fact, many of the haters would say, look, people just lose weight because they're nauseous all the time and thrown up, which is plausible, I suppose. If people are, you get sick from a GI bug and you don't want to eat, you lose some weight. And if you feel like that all the time, that can make sense. But when you look at the data, it's pretty clear that the nausea is the highest in the beginning, and then the longer you're on the medicine, it tends to go away for pretty much everybody. For most people, it's mild to moderate at first. Once in a while, it's more moderate to severe, where you have to intervene with an anti-nausea medicine. We try to minimize it with our diet. I have dietitians, and we try to promote kind of a lower fat diet. Now, there's reasons why this may be higher fatty. So, like chips, fries, pizza, burgers, wings, that type of thing may be increasing that nausea in the beginning. It could be because the gastric emptying is slowing, so you put more fat in the gut, and then it's more having an increase in other things like CCK and other hormones that from the fat intake that can also increase nausea. So potentially, I don't know what, but lower fat diets tend to help minimize this, and maybe smaller, maybe more frequent meals, not to boost your metabolism or anything like that, but to help with the nausea. And you don't have to do that long term. It's the nausea is high in the beginning. When you look at the trial data, it doesn't matter what trial it is, semaglutide, tirzepatide, they show the trial data, it's all peaked up in the beginning. And then as the trial goes on, the nausea goes down. Sometimes we have to do Zofran or ondansetron to help with the nausea. In general, though, most people don't have to do that. So that's number one. I do see a lot of constipation. Unlike nausea, it's constant, so you have to get in front of it early. Lots of fiber, lots of fluid, physical activity, the very standard things we do for constipation. Sometimes we add a laxative or add some fiber supplements and things like that. But constipation's pretty common. Try to get in front of it to minimize that. Reflux, if you're slowing down the gastric emptying in your stomach, there's more of a chance for food and stuff to come back up your esophagus, cause reflux. So we do see that. So people with a history of reflux, we're like, all right, we got to be careful here. You might get some worsening. Don't stop your omeprazole or whatever right now. Sometimes they need to add it back in for a little bit. Hopefully over time that improves, and generally we see that improve because that gastric emptying is higher in the beginning and then wanes or even goes down a lot at the end of or while you're on the drug longer. We do see diarrhea, usually self-limited. Uh, Generally, we try to help people bulk up their stools but it's usually self-limited. Sometimes I do Pepto, sometimes I do Imodium. Generally, something that goes away over time. We see fatigue. A lot of people thought, oh, yeah, you're not eating, you're going to be tired. There's something about the drug, and this likely has to do with the brain effects of the drug, the receptor agonism in the drug, where we were talking about the dopamine, where people feel like not as addictive, but sometimes it's got a pretty strong effect up there. Almost they feel like an anhedonia, like just kind of like they feel unmotivated and tired. That happens. Sometimes we got to adjust the dose. Sometimes it's just at the beginning. The fatigue generally goes away by itself, though, and a lot of people argue over the cause of it, but it's likely in the brain. Some of it may be because you're not eating as much, but you'll feel it like a couple days after your shot, and then it goes away after a few more days. Kind of interesting. Uh, Worst side effect, gallstones probably. We see that because of weight loss. Likely there may be an effect of GLP-1 on the actual gallbladder and changes of how it's moving. We can see gallstones precipitate. But we see that with any type of weight loss, bariatric surgery. And from that, we can see, the cholecystitis or gallbladder attacks, rarely pancreatitis. When you look at when you compare placebo to the active drug in these big, huge trials, they put them together in a meta-analysis. There doesn't seem to be a statistical difference between the drug and a placebo. But patients are like, yeah, it causes pancreatitis. So it's not different from placebo. So those are the common things we can. I don't know if you want to. Austin wants to talk about the black box warning of thyroid cancer and all the scary things people talk about, but those are kind of the common things.
Yeah, I was going to echo much of what you said, and the pancreatitis one is interesting for several reasons because pancreatitis is a relatively common condition. Like it's something that also just happens to people sometimes in general. It happens relating to alcohol use pretty often. It can happen relating to gallstone related causes very often as well. And I see it very regularly in the hospital setting. And so given that there's a relatively high, what we'll call like base rate of people experiencing pancreatitis, that also increases the risk of also there's a high base rate of people getting put on these medicines. And so there's going to be a scenario where somebody gets put on one of these medicines, and because they were just existing, they were going to get pancreatitis anyway. And humans, that what we do in our brains is we tend to, observe patterns and assume causation between them. Well, I started this medicine and afterwards I got pancreatitis, so it must be that one caused the other. And that is a reasonable hypothesis to have, but that's also why we benefit from having controlled trials. And that's where this interesting observation comes from in the controlled trials, that when we compare people on drug versus on placebo, we don't actually see a significant difference in that pancreatitis risk, even though there is a higher risk of developing gallstones relating to the rapid weight loss. It's like all the signs you would expect there to be a signal, but it doesn't actually lead to the outcome that you would expect, which is, again, why we benefit from these kind of studies and why all three of us get in arguments on threads all the time, because people make arguments based on vibes or observations or just assuming patterns exist, whereas when we actually control the data to account for our own flawed assumptions and a tendency to draw patterns where none might exist, we actually can get to the truth of the matter. So pancreatitis ends up being something that I don't tend to routinely counsel on, because what are you going to do aside from, well, I already advised that you probably shouldn't be drinking very much. We're advising weight loss regardless here, and so there's a risk of gallstone development with rapid weight loss no matter how we go about it, and that's something that we can be attentive to and intervene on if we need to. So that's just an interesting aspect of the data, that all the things that you might observe or anecdotally hear or expect based on some of these things don't actually tend to pan out the way that we thought.
Yeah. And just lastly, before we get into some of the body composition and performance stuff, Dr. Nadolsky, there's been some concern about this non-arteritic anterior ischemic optic neuropathy, or NAION. This irreversible eye condition causes partial or complete vision loss in one or both eyes. And isn't there a major lawsuit against Novo Nordisk right now, for that? You see that all over the place. There's a $2 billion lawsuit against the manufacturers because these drugs, so they don't want you to know. They're taking your vision. Is any merit to that?
Yeah, notice it's not against Eli Lilly. I'm kidding. I'm kidding. Someone from those pharmacies, they're going to come get me. I'm actually friends with a lot of those people. And they're always switching teams all the time, so it doesn't really matter. But it is true, there are some lawsuits out there. It's a rare risk. We had my buddy, an ophthalmologist, retinal specialist on. There was a JAMA article last year that looked at a group of people on semaglutide with type 2 diabetes that showed maybe a small, maybe 1 in 10,000 people, increased risk of people on the medicine, maybe an increased risk of this type of blindness. But then more recently this year in Journal of Ophthalmology, they showed maybe a trend towards a decreased risk, at least not statistically significant, just no statistical significant risk compared to people not taking the medicine in a similar population. So if it is a risk, and what my friend told me is that we see it from people's blood pressure going down, and usually in the middle of the night. So I could see it where the medicine, it's just so powerful, and people are still on their blood pressure medicine. They may have sleep apnea where they're going apneic and not getting as much blood flow and oxygen into their blood, where there maybe there's some sort of risk there. But the most recent data doesn't show the signal. If it is there, it's extremely rare. It hasn't been seen in any of the weight loss data. It's only in these patients with type 2 diabetes where maybe there's an increased risk anyway. I'm not super concerned, but patients are concerned. I wouldn't want to go blind. So we try to, talk about these, try to talk about the data. I would just say, look, the signal's not there in the most recent analysis. It's in semaglutide only in those with type 2 diabetes. Potentially, maybe there's some plausibility there, but I would just, if it's there, it's extremely rare.
Yeah. All right. I feel satisfied there. We can now move on to some of the other risks and potential side effects that would maybe be pertinent to our listenership, because we're talking about gains, we're talking about body composition and performance. So, Austin, a lot of people talk about the potential risk of losing all of your muscle when you go on these agents. Maybe speak more broadly about, well, look, why is losing lean body mass a problem with weight loss in general? And then what is the long-term consequence of that, for health and performance?
Yeah, before we get into that, I do think it's worth pointing out, because a lot of these terms can get conflated and definitions can get baked into one another in ways where one audience might hear and interpret this term lean body mass in one way where it's not necessarily being intended in that exact way. Mm-hmm. body composition science is complicated, and I know Spencer will get into this a little bit as well. But what does lean body mass mean? What does fat-free mass mean? What does muscle mass mean? All these things have very specific definitions, and so it's important to be clear on what you're talking about. So the haters, as Spencer referred them, described them earlier, use this kind of terminology, and they seem to imply that these drugs have a unique effect on reducing or impairing your muscle mass in particular, potentially baking in bone into that as well. And that's a strong claim that would require direct evidence showing that when these medicines are used, that there is a substantially greater degree of specifically muscle mass and or bone mass compared with equivalent amounts of weight loss by other means. When we look at this, we'll get into the specifics of what's observed, but it is a valid concern, just to address your question directly, that if people are losing significant amounts of muscle mass and bone mass, yeah, I would have some concerns about that. I see the end stages of frailty, cachexia, people who have severe sarcopenia, osteopenia, osteoporosis, people who fall, they lose their physical independence, they have fractures, they need to go to nursing homes, things like that. I've been seeing that my entire medical career so far in the hospital setting, and it's not like I have seen, for example, over the course of the past decade, I'm admitting these people left and right for GLP-1 induced osteosarcopenia, and they're all needing to go to nursing homes because they can't stand up out of a chair anymore, right? And so that's kind of where a strong claim is going to need some strong evidence to support it, or, we need to look at it more directly. So those are some of the reasons why we care about lean body mass, is that risk of long-term musculoskeletal health, physical function, independence, things like that. And so that would be the question, is do we see higher rates of those things specifically being impaired from the use of these medicines compared with if you lost 15%, 20%, 25%, whatever amount of weight loss through diet or through metabolic bariatric surgery? Do you see that more? Do you see it less? Does it seem to be about the same? Are there ways, if it's a real thing, can we mitigate it? And what exactly are we talking about? Is it muscle? Is it bone? Is it just lean body mass, which includes body water, all sorts of other tissue compartments and things like that, organ mass, stuff like that. So that's kind of my broad take on it.
Yeah. Just to summarize for the listenership, the claim is, by, again, the haters, is that these particular drugs, these anti-obesity medications at large, have a unique effect on the skeletal muscle tissue that results in more proportional muscle loss per unit weight loss. And what's widely quoted in the literature for just like diet-induced weight loss is that about 75% of the weight you lose is going to be fat mass, and 25% is going to be not fat mass. And some of that is going to be actual skeletal muscle fibers, but to Austin's point, some of it's just going to be other things that aren't muscle, but are also not fat. And so literature then would show you that per pound people lose when they take these medications, that more than 25% would be not fat mass that people were losing. So the question to you, Dr. Nadolsky, is what do you think about the actual risk of losing skeletal muscle mass in relationship to these drugs? I mean, again, there's been a problem that's been a lot of concern over this on social media, especially in the fitness space. Is this a real risk? Like, is this real?
Yeah, some history around it really is the Peter Tia, which my brother and I call our podcast the Peter Tia Hater Podcast, in not because he's generally okay. It's just some hyperbolic statements. He was on the Megyn Kelly show a couple of years ago and said that his patient got fatter, quote, fatter on this medicine. They lost more muscle than they did fat. It's kind of interesting, nice anecdote there. But then he has pulled up that the STEP trials, there was a subgroup analysis. They did a subgroup DEXA of some of these patients that used semaglutide in the STEP trials, which was the obesity trials with semaglutide, high-dose semaglutide. And it looked like somewhere around 38 or 39% fat-free mass loss. So it's kind of like, well, that is more than we'd expect. But Dr. Baraki said fat-free mass loss isn't necessarily muscle. So when you look at a DEXA scan, and this is why I have Chief Science Officer Grant Tinsley. He's literally a body composition expert. He would talk circles around me in terms of how to look at these different compartment models where they look at body composition, because a DEXA scan, you're like, oh yeah, you got your body fat percentage there, but it's because it looks at fat-free mass and fat mass. And so like pretty much everything that's not fat mass. It's like, oh, they lost this much fat-free mass, but a lot of that includes glycogen. Is the interesting thing when they did these same subgroup analysis in the Surmount data, the Tirzepatide data, it was around 25%. So
Hmm.
a stronger drug that resulted in more weight loss actually resulted in about what we would expect amount of fat-free mass loss, which we assume, if we're just making assumptions, has a similar composition of that fat-free mass loss with muscle. So similar to what we'd see with just dieting alone or bariatric surgery alone. So then the claim would have to be something about semaglutide specifically is extra catabolic beyond its ability to help people lose weight, beyond this calorie deficit. And there's nothing biologically plausible to make that accurate. What I personally think is that there's some sort of fluid shift because of the GLP-1 receptors. Dr. Baraki talked about the kidneys in the flow trial. I don't know if there's some diuresis effect, there's some fluid shifting, but it's very possible what looks like an increased fat-free mass loss is literally glycogen or fluid changes. That's what I think, because otherwise it doesn't really make sense. Now, having said that, we are doing studies in our online clinic. So we partnered with DexaFit, and Dr. Tinsley is doing all this, where he actually looks at lean soft tissue. So trying to nail it down to closer to the muscle tissue. And we did a case series, but we have a whole cohort going on. We don't have the data from that yet. And it looks like if you just lift some weights, and we're not talking about like barbell medicine style, you're freaking obsessed with it. Even if you're just kind of like doing like basic 2 days a week of like what would be recommended and eating sufficient amounts of protein, you're not loading up your each plate with protein and eating, a gram per pound of body weight. We're talking like 1 to 1.2 grams per kilogram of body weight, even somewhere around there, with just a couple to 2 to 3 days a week of resistance training, full body or splits. You pretty much mitigate it all or minimize it all. So I'm not worried. I think it's good that it's brought this whole thing to the forefront, but I think the whole concern is overblown. And I think it's just a reason for what we call weight stigma, where it's like, no, we don't want people to lose weight. They reduce their risk of heart attacks. They have less liver disease and kidney disease and fewer strokes. But oh my God, they lost some extra fat-free mass in there. So watch out. These drugs are bad. I think it's just people are looking for a smoking gun to say, see, you can't get out of the hard work. And that's my probably my biased opinion. But I just from a clinical standpoint, I'm not concerned. I want people to lift weights and eat protein, but like I'm not concerned if like they don't and they lose this amount of fat-free mass percentage-wise.
Yeah. Yeah. Two additional points. If you actually look at that subgroup analysis in the STEP trial and you look at the placebo group who was just doing lifestyle stuff alone, they also lost more proportional lean mass than you'd expect. So to me, it almost is like perhaps there's an artifact of the measurement technique, or at least that's a possibility.
Yeah.
But even the latest trial, the Sema-Lean study, where they had folks on max dose semaglutide and then they did DEXA scans on all these people, it wasn't 75-25, it was 80-20. I was like, ooh, that's interesting. Is there a muscle preservation effect, perhaps, even? And there's some animal models to support that. I don't think that's true. To me, that seems like within the realm of like what's expected. But I just find that these concerns about losing so much muscle mass that now you have sarcopenia because of reduced muscle function from all that muscle loss due to these medications, that seems like an overblown risk compared to the potential benefits everywhere else across the board. Yes, if you have somebody where you have concerns about frailty initially, they're probably not a great candidate for a GLP-1 or other anti-obesity medication, although that does get a little more tricky when you even talk about like sarcopenic obesity, because that was also assessed in the Sema-Lean study where 49% of the starting population had sarcopenia as diagnosed by, I think it was hand grip strength and the appendicular skeletal muscle mass. And then at the end of the year, only 33% had it. So it seemed like even though they lost maybe some lean mass, their actual function or muscle quality improved. So I don't know. It seems pretty interesting to me.
Yeah, this is just not fundamentally a major concern that I have. I agree with Spencer's take in general, and just look at the major outcomes that we care about. And if somebody says, well, the outcome that I care about is my lean my lean mass, and I don't actually care about cardiovascular risk and kidney risk and fatty liver risk and diabetes risk, and I'm unconcerned with the amount of fat mass the person carries, this is my like myopic focus is just on lean mass. Okay, don't take the drug. Like nobody's forcing you to take it. But every other area of health and like what we'll call hard outcomes, things that we really care about the most, seem to be benefited. And if we were seeing, because we know that sarcopenia, for example, and osteopenia and osteoporosis, they increase the risk of certain things. And so if those risks panned out, we would expect to see those signals in the data. I would expect to see, oh gosh, we're seeing way more hip fractures in these patients, or we're seeing way more falls, or we're seeing, all sorts. And it's like, if that doesn't show up, then this remains in the realm of hypothesis, but not something that's going to impact my clinical decision making. So yeah, I agree. It doesn't take a ton of training, and it doesn't actually take a ton of protein to mitigate lean mass loss to the extent it's going to happen here, especially in undertrained or insufficiently active people at the start. And the training is the thing that I emphasize even more than the protein. Like if somebody is willing to do a bit of exercise, I am going to put not that I'm going to put less emphasis on protein, but it's not my like major lever that I care about. Getting people active in general, not just for the lean mass, but for all sorts of other health benefits is my like strongest, heaviest emphasis for people, and always has been, even before these drugs ever existed.
Yeah, if you looked at like an equalizer, like you got a 7-band equalizer, and these are all the variables that affect like the proportion of mass compartments that are lost. And so you have things like sleep, you have protein intake, you have these medication use, whatever. All well and good, all can certainly affect that, but exercise, specifically resistance training, is the volume knob. Like that is the main controller here. And so without resistance training, all of these other things the effects are so much smaller. And so, eventually we're going to get a study where people are using these agents and actually lifting weights. Like no shit, they're actually lifting weights. And then we're going to see the results. I suspect they'll be very positive. And then at that point, we should follow up with the TIA, with some other folks who have expressed strong concerns about this, and be like, what now?
Yeah, there's a study they presented it. It's not published. It's called the T-Rex study. So funny story. My brother and I, with Brad Schoenfeld, if you know who that is, went to Lilly again. I'm like, come on, I'm the biggest Lilly lover, but they decided to go with a different study team. Apparently, they probably a good choice. They're like, who the hell is this guy on podcast? He doesn't know what the hell he's doing. But they chose a different team. But they showed it. I saw the slides from the conference where they showed a decrease compared to, I believe, the standard of care group, a decrease in fat-free mass loss. So as we'd expect. And so it was pretty, they cut it in half. And that's kind of what I'm seeing. I'm seeing cutting in half versus like none at all when people are lifting weights. So pretty cool.
Yeah. So basically, again, what I'm hearing you say is that if you take Tirzepatide, put creatine plus resistance training and a little bit of TRT, it's basically a PED cocktail. Is that what we're talking about here?
Yeah. And I mean, I'm sure, have you talked about all the myostatin inhibitors yet on the podcast? I mean, they're studying it. The thing is, it might be overblown. Like of course, barbell medicine, I'm obsessed with muscle and that type of thing. Is it possible that we're overstating the benefit? We don't want people to get frail, but like, is it possible that we're overemphasizing it? I don't know. We'll see. Because if people live longer and live better with these myostatin inhibitor drugs, then everybody's going to be jacked, ripped, and just like, it's going to be an interesting time. I don't know.
Yeah, you just walk around, and at that point, we will have to reject BMI. There'll just be too many jacked people just walking around, and we're like, all right, well, we need another scale here. So
yeah, like forget BMI. I mean, yeah, it's actually, that was a big part of the conference, and not another tangent, but like going way past the BMI at this point. I'm sure you've talked about this, but we know that the BMI is actually, it does a decent job. Where not everybody's a NFL linebacker. Most people are not an NFL linebacker walking into the clinic. Not everybody's Jordan and Austin walking into the clinic. And if they were, I would look at them and be like, who cares what their BMI is? Somebody should do that. But pretty cool that we are looking at body composition. I think it's important.
Yeah. All right. Well, let's wrap this up with maybe one of the more controversial parts of this podcast. We save it for last because if people tuned out, then they won't send us hate mail. How hard is it to get these medications? We've got some new government policies potentially coming down the pike. It's going to make these more accessible. But to you, Spencer, what is the biggest hurdle for people to like gain access and maintain access to these sort of medications?
Yeah, it's cost. The costs are ridiculous. You see it over here in the United States. There's these middlemen, these pharmacy benefit managers, and because of rebates and the way they structure it, and with the manufacturers, and then go to the insurances and the pharmacies, they, instead of being like 500, $600 net price, they see this list price of $1,200 at the pharmacy. 20 to 30% of commercial insurances approve it. Actually, it's probably going to go down here because of the cost of these medicines. So that is probably the biggest thing we see. We're going to see that improved over this next few years, though. They just announced lowering the prices if you go directly with the manufacturer. There's some new prices with Medicare that we weren't seeing before that just were announced. So price, by far price. It used to be, well, price and then access. There's a lot of weight stigma, but now everybody's asking about them. Primary care doctors are feeling more comfortable with them. So like the access isn't as big of a deal with finding a doctor who's comfortable doing it. It's really the cost. And I think we're going to see in 5 to 10 years, just the prices are going to be very low, but it's not so much right now.
What is the role of Vineyard? Like, how does Vineyard fit into to all of this for access and maybe making sure that people are getting the lowest available cost? Is that something that Vineyard does?
Yeah. So our biggest thing is like, look, because primary care offices aren't equipped with prior authorization specialists, they don't even, I mean, we get referrals from primary care because their back office simply cannot handle the amount of prior authorizations. Everybody knows what that is. You're basically asking insurance permission. Can I write this drug that I recommend for my patient? And you have to jump through these hoops of answering all these questions. They make it tougher and tougher because they don't want to pay. And so I was like, all right, this is one of the biggest pain points. I have to hire a prior authorization specialist to handhold the process of going through that. So that's one thing. Obviously, we're specialists in the field to where like we know the dosing better, we know the interactions and how to adjust other medications with losing weight. We're going to focus on resistance training. We have dietitians to minimize side effects and optimize your whole journey. So that's the big thing. And we're going to try to get it the lowest cost possible for you, but we're also going to handhold you through the process to make sure your side effects are minimized, your body composition is optimized, and you just have the best time. And you can chat with us online, texting us, as opposed to waiting a whole month to go see your primary care doctor. That's just, it's very quick replies, but also expertise is unparalleled.
This is actually a little tangent to that topic about cost. And the way I view it and the way I kind of explain it is that you have these not only brand name, but just prescription medications, and those are the highest cost tier. And then you have compounded versions, which you still need a prescription to obtain, but much lower cost. And then you have research chemicals, which are even lower cost and you don't need a prescription for. How do you kind of view the risk benefit analysis across that continuum? And do you have these conversations regularly with patients because they're like, look, I like what you're saying. I like the benefits, but that price point is just too much. So is there ever like a scenario where you think of like permissive use? You're like, oh, look, man, I don't love these compounded versions, but I actually think the benefits outweigh the potential risks. Like, yeah, how do you talk about that?
Yeah, the problem with the compounded versions is that they haven't been studied for safety or efficacy. Now, if you look at, you can see Reddit. I have had patients come from the compounded versions. They've lost plenty of weight, but because of the nature of the compounded industry, you'll never have safety data. You can't do an FDA, you can't do a trial because the ethics committee would be like, no, you got to use an FDA branded version. There's concerns over where they're getting the sourced active pharmaceutical ingredient, and if they're making it in a certain way that's making immunogenic material that wasn't detected. It's a lot of different things, and that might be big pharma fear mongering against the compounded version. So I usually just say, look, if you can't afford the FDA approved versions and you can't get it direct, like it's getting a lot cheaper now and it's getting almost similar costs to the compound. It's still more expensive. I can't personally attest to the safety of the compounded versions. I sure as heck can attest to the research grade peptides. Now, the thing is, you'll see there'll be some analysis where it's like 99.5% pure. It would be as pure as a pharmaceutical grade version, and then they'll do an analysis on the next batch and there's nothing in it. It's actually insane. So like you would have to verify every single batch that you got. I wouldn't mess around. I would never have a family member mess around with research grade. I wouldn't recommend compounded versions, but I'm in a, if you want to call it, a privileged position to where, like, we could get them the FDA approved versions. So I don't get mad at people for going to the compounded versions because of affordability. What I do say is that the pain of that in the next few years, I think it's going to be we're going to look back and be like, oh wow, those are crazy times, because the drugs are going to get so much cheaper, and you'd be stupid not to get the FDA approved version because they're going to be so much cheaper. Again, we're just going to go through the pain in the next few years, unfortunately, to get there.
All right. Final question to Dr. Baraki. Well, look, we've been talking about semaglutide, tirzepatide, and the future. What about older anti-obesity medications? And, what about microdosing? Because people talk about that too. So yeah, thoughts on some of these older medications and also microdosing, because we want to be fashionable.
Yeah, I think the question about older meds fits in nicely with the conversation that you just had around, balancing risks and benefits of, the non-FDA approved versions. If you're either considering a compounded version, or you're going like Chinese bathtub level peptide or something like that. Because we have at least as much, arguably much even more experience with some of the older anti-obesity medicines. Now, what are the downsides of them? Many of them are not quite as potent in terms of their efficacy. Some of them come close, but the upside is that in general they are way cheaper. They have maybe some of their own inconveniences. I've had plenty of patients, for example. The brand name Qsymia or phentermine topiramate is one that is probably the most potent and has the best efficacy among the older ones. It's an oral agent. When it comes in the combination form that's branded, it might be a little bit less accessible for some folks, but it's also something that for somebody who's willing to go through with it and deal with a little bit more inconvenience, prescribe the meds separately in generic form, and it can do its thing, potentially as a way to get people through this like temporary, ideally, period of discomfort or pain that Spencer described until the cost and the prices come down. So I think they do still have a role for now. They can be used in conjunction with GLP-1s. They can be used on their own. They can be a bridge on or a bridge off. There's all sorts of different creative strategies that we can use when using things like, again, phentermine topiramate. Less favored is going to be bupropion naltrexone, but I've had plenty of patients who've used it with varying levels of success. Some who did great, some who didn't do as well, some who didn't get as much who kind of fell somewhere in between, which is going to be the case for most interventions. And then some patients who have very interesting, maybe disproportionate responses to certain things, to phentermine monotherapy just by itself, which is not something that many of us use too often anymore, but once in a while a patient will respond really well to that, or to topiramate, or to some antidepressant category type medicines that for some patients have appetite modifying type effects and things like that. So bottom line is they do still have a role. They tend to be less expensive. They have their own unique pros and cons that you need somebody who has expertise and experience with them to be able to discuss with the patient, and then be able to monitor their therapy and things like that over time, and hopefully to keep kind of poking at this and engaging with this process to see, well, when does the cost benefit become within reach for you, or become accessible, or do you maybe unfortunately develop a condition that would qualify you for one of these things in a different way? These are all things that we'd be paying attention to. So that's my take on the older meds. And then lastly, the microdosing topic, that's another thing that you'll see popularly on social media. It's not something that I don't think either of us is going to routinely be recommending for people, mainly because we don't have the quality of evidence behind those strategies for the types of outcomes that we're looking for in terms of, be it weight loss, blood sugar control, cardiovascular risk, kidney, liver, all these other sorts of things. I can't say with confidence that using those levels of doses is going to get you those outcomes that you might be interested in. Now, the caveat there is that when you are an independent practicing clinician who feels confident with your, with your practice, because I end up doing this with a lot of other things, you can do stuff off label all the time if you are comfortable with it, if you have a sense of the potential benefits, the potential risks. You're able to discuss this with your patient. And so where that might come more into play, and probably does more regularly come into play, is dosing for tolerability, right? And so we know that tolerance, the side effect risks that we talked about earlier, the overwhelming majority of it is going to relate to dosage. And so tinkering with dosages is probably the way that we end up dealing with most of the side effect kind of profiles, whether going to, even tinier doses or stretching out that on-ramp process to be even longer. A lot of the traditional dosing regimens, it's you go on this dose for 4 weeks and then you bump it up from there, et cetera. I could stretch that out longer if I wanted to. I could keep you on a lower dose for longer or increment you in a smaller way. If you're comfortable with these things, you can use those types of strategies. But it's not going to be a standard recommendation for us at this time unless we have better quality data. I'm not going to go out making grandiose claims about if you just microdose, you'll get these like life-changing benefits with no, side effects or risks or something like that. I don't have concerns about risks at the very low doses, and that's why we would use those potentially as a strategy for tolerability, but not really so much outside of that. So that's my take there.
Excellent. All right. Well, to sum up, the data is clear. The new anti-obesity medications, especially those targeting multiple receptor pathways, well, they're offering efficacy that rivals metabolic and bariatric surgery with improved tolerability, and they're showing clear benefits for cardiovascular, kidney, and liver health with additional potential in the future. If you'd like to have a discussion with professionals about this, you can click on the link in our description below in the show notes. You can connect with professionals at Vineyard. That's Dr. Nadolsky's company, and Austin will be starting there shortly. So if you want to work with Dr. Baraki there, and it's not just weight loss. Spencer, can you talk to about some of the other stuff that you guys deal with? I know you mentioned cardiometabolic health at the onset, but what can people expect if they end up heading to Vineyard?
Yeah, so think about obesity, but also obesity adjacent cardiometabolic health, lipids, cholesterol. We also help with easy things like hair loss. If you're losing your hair from the weight loss, we can jump in with minoxidil. If you're a guy and you just have androgenic hair loss, we can do a little finasteride. We can't call ourselves primary care. We like to stick to the cardiometabolic, but we can do some of these other things that, places, these pill mills that you see where you pay $50 a month. We can send it to places like Mark Cuban if your insurance doesn't cover it. So even skincare like tretinoin, but think about blood pressure, lipid, glycemic control, and weight losses in general, and then anything kind of adjacent to that.
There you go. And for all your training and nutrition needs, you can check out Barbell Medicine. But before you guys go anywhere, please leave us a 5-star rating and a review. It really helps drive traffic to our podcast so we can keep bringing you all the latest nuance in health and fitness. A special shout out to Dr. Nadolsky and Dr. Baraki for joining me, Dr. Jordan Feigenbaum, on the Barbell Medicine podcast. We'll catch you next week and every week right here on the Barbell Medicine podcast.